So thank you all for inviting me. I'd like to thank the organizers, and it's a pleasure to be here on a Sunday morning. Shivam has made my talk a little sort of easier in a way, because this is another new kid on the block, not really new, for ALK positive NSCLC. So I'm going to present the results of the ALTA first line trial or 1L trial, which looked at Brigatinib versus Crizotinib in first line setting or ALK inhibitor naive advanced ALK positive NSCLC. And these are the final results which were presented in Journal of Thoracic Oncology last year. So in ALK positive NSCLC, we know that Crizotinib has shown a superiority over a platinum-based doublet chemotherapy, 10.9 versus 7.0 months of progression-free survival. So what is so special about Brigatinib? Of course, it is a next-generation ALK-ROS inhibitor, and it has activity against certain ALK inhibitor-resistant mutations and EGFR mutations in vitro as well as in mouse models. And there have been phase 1 and 2 trials which have evaluated Brigatinib after Crizotinib and have reported higher rates of response systemically and in the CNS, which is one of the most important sites of metastasis in a non-small cell lung cancer, and improving the progression-free survival. So this basically article has reported the final efficacy, safety, and certain exploratory results of the study. So this is just to show you the resistance mechanism. So there are so many resistance mechanisms here, and if you see, Brigatinib is almost effective against most of them, and that's why it's a very promising new kid on the block. So the study design of ALTA-1L, patients with advanced ALK positive NSCLC, no prior ALK inhibitor used, they were allowed less than or equal to just one systemic cytotoxic therapy. They were also patients who had asymptomatic or stable brain mets were also allowed, and these patients were actually stratified by presence of brain mets at baseline or prior chemotherapy. Patients were randomized to receive either Brigatinib 180 after a 7-day lead-in period of 90 milligram for the pulmonary toxicity, and then or Crizotinib 250 milligram BD. Interestingly, the crossover was allowed. So those patients who progressed on Crizotinib were allowed to cross over to the Brigatinib arm. The primary endpoint was progression-free survival. Secondary endpoints were overall response rates, intracranial response rates, intracranial progression-free survival, overall survival, duration of response, safety, and the quality of life. They had certain exploratory endpoints also, where they looked at patients who, progression-free survival as well as overall response rate in patients who crossed over to Brigatinib after progression on Crizotinib. They tried to look at certain molecular determinants. We know the variants and their prognosis. So they also tried to look at that, and they also tried to look at the emerging mutations while patients are on Brigatinib while over time. So these are the baseline characteristics. They were quite well matched. If you see, most patients had stage 4 disease with a performance score of 0 to 1. And there were about at least 29 or 30 patients in each arm who had baseline brain mets. An equal number of these patients had received radiotherapy to the brain. At the end of this study, there were about 58 patients, so 42% of patients were still continuing Brigatinib compared to 12% who were continuing Crizotinib. And the median follow-up was 40 months in Brigatinib arm compared to Crizotinib, it was 15.2 months. And there were 65 patients who actually crossed over to Brigatinib after discontinuing Crizotinib due to progressive disease. So this is the primary endpoint. The blinded independent review committee assessed progression-free survival, and you can see that the curves are wide apart. So definitely there was an improvement in median progression-free survival. BIRC assessed as well as investigator assessed median PFS of 24 months versus 11.1 months. So there's almost more than doubling of the progression-free survival in patients who were on Brigatinib compared to Crizotinib. They also did a pre-specified subgroup analysis, and most patients had found that Brigatinib was better, except for maybe patients who had age more than 65 years. But even if you look at brain metastasis at baseline, those patients actually had far better PFS with Brigatinib compared to Crizotinib. So this is what we see, the intracranial progression-free survival, and you can see here again that Brigatinib fares far better than Crizotinib, where intracranial progression-free survival is concerned. Again, it's 24 months with Brigatinib compared to 5.5 months with Crizotinib. Similarly, even this is with patients who had a brain metastasis at baseline. Although the numbers are small, only 47 in Brigatinib and 49 in Crizotinib. If you look at in intent to treat population also, it shows that the intracranial progression was better with Brigatinib compared to Crizotinib. Coming to overall survival. So the overall survival data is still maturing. There have been about 30% of expected events. And in the intent to treat population, if you see, there was no difference, statistically significant difference in the overall survival with a p-value of 0.3. However, in patients who had brain metastasis at baseline, they saw that the overall survival was slightly better. Again, these numbers are small for comparison, but definitely it's a promising drug for those patients, especially who have brain metastasis. And to also note that there were 65 patients who crossed over from Crizotinib to Brigatinib arm or at progression. So they did a sort of a sensitivity analysis to account for these patients. And when they did the sensitivity analysis, they found that Brigatinib was better indeed than Crizotinib. So this is just, I'll just rush to the last few slides. So the exploratory analysis, which looked at molecular variants, they still showed that V3 fared worse than V1. And patients who had a TP53 mutant strain, they also had a worse outcome compared to the TP53 wild type in spite of on Brigatinib or Crizotinib. When they looked at the quality of life was slightly better maybe with Brigatinib, but the median time to worsening was longer with Brigatinib, 26.7 months compared to 8.3 months with Crizotinib. We're always worried about safety, and there was something that we saw was more grade 3 and 4 adverse events were more common with Brigatinib compared to Crizotinib, and rates of dose reduction and dose interruption and treatment discontinuation were also more seen with Brigatinib than Crizotinib. Commonest side effects we saw was CPK increase, lipase, hypertension, amylase. And the most important thing that we are worried about is the ILD or pneumonitis, which is known with Brigatinib, was seen in 6% versus 2%. And in 3% of these patients, it was seen within 14 days of starting treatment. And that is why the lead-in period of 90, because some of the patients can develop ILD early before we go ahead with the 180-degree dosing. So to conclude, in ALK inhibitor naive patients, the final analysis of this study showed that there is definitely an improved PFS with Brigatinib over Crizotinib, 24 versus 11.1 months. And it is observed across most subgroups except for maybe those older than 65 years. Intracranial PFS was much better in patients receiving Brigatinib, including those who had baseline brain metastasis. And what they found is there was no clear pattern of emerging mutations where you see, resistant mutations coming up, but there were no such clear pattern that they noted in patients who had a progression on Brigatinib. Although toxicity was higher with more dose interruptions and discontinuations. So this does remain a promising first-line option for treatment with ALK-positive NSCLC, especially for those with brain metastasis at baseline. So we have a lot of drugs now, Alectinib, Lorlatinib, and Brigatinib, all with good intracranial activity. So I think where these drugs lie, because there's not going to be a head-to-head comparison with, between these drugs, so where these drugs lie in this whole armament is going to be very interesting. Thank you so much.